Okay, hello everyone. Alexis, I saw your question, so I'll get to yours first. Just let me know if everything sounds okay. Um, so the issue with ventilation and perfusion. So here are the lungs. Okay, sounds good. Let me just bring this up on my phone so I can actually read them now because I'm blind. Okay. So at normal rest, upright standing here, everything up here at the apex, very, very high ventilation, but they're not perfused because of gravity is pulling the blood down to the base of the lungs. So we call it alveolar dead space. So high V, very low Q, alveolar dead space, the number goes high and high and higher. At the bases, it's more of what you said the second part of your question there, that it is at the bases, and I'll change the color here. In the bases, and I'll put it as orange, and then I'll get it erased. Okay. We have normal ventilation, and we now have normal perfusion at the bases. So I hope that answers your question regarding perfusion and ventilation relationships. At the apices, they are ventilated, so you do have your normal 4 liters per minute for ventilation, but they're not being perfused, so the bottom number drops low. So remember, normal Q is 4 over 5, and that gives us our magic number of 0.80. For your normal VQ ratio, that's your normal number because that's a normal liters per minute and a normal perfusion cardiac output at 5 liters per minute. Now, in alveolar dead space, we're still at 4 liters per minute because we are still ventilating, but now we are not perfusing. So let's say it goes down to 1 liter per minute. So now our VQ is 4. So when you are ventilating but not perfusing, it goes up and up and up. Okay. You can't see my writing. Okay. Uh-oh. Nope, that's not it. Okay, hang on. Let me just start this over again. There we go. Okay, let me start over this all over again. Okay, let's start over. Let me make sure I'm caught up on chat. Hang on 1 second. Okay. There we go. Now you can see lungs. We all good now? Horrible drawing of lungs, but they'll get better. So at the apices, we have very good ventilation, but we don't have any perfusion because of gravity pulling all that blood down. So the blood, high perfusion, is at the bases. So at the base, we have normal ventilation and we have normal perfusion. And at the apices, we have normal ventilation but low perfusion. So again, to review, VQ, a normal ventilation is 4 liters per minute. A normal cardiac output is 5 liters per minute. And that gives us the 0.8 that you'll see with, that's our normal VQ ratio of 0.8. So let's give an example now. We'll talk about the apex. Ventilation is still normal at the apices, but cardiac output perfusion goes down because it has to go against gravity to get up to the apices. So let's say cardiac output drops to 2 liters per minute. So now our VQ is 2. So when you have ventilation issues, the VQ rises. Now at the base, everything goes back to normal. But let's say now, let me erase this. Now let's say the person has a pulmonary embolism, which is going to be going up higher and higher and higher. No, I'm sorry. Let's go back to that one. Let's go to COPD, because that's be the same exact example. COPD. Now we have a ventilation problem. So ventilation goes to 2 liters per minute. Cardiac output is still the same, 5 liters per minute. So you see now how the VQ starts dropping because the top number gets lower and lower and lower. So at the bases, ventilation and perfusion are normal. So in the slide, the way it was written was just saying that when you compare them to each other, at the bases, they're at their normal perfusion, normal ventilation, but at the apices, because of gravity, we know it pulls it all down, we lose perfusion at the apices. Before I move on, Alexis, just what COPD are you referring to? So just make sure, just let me know which one, because it's going to be different regarding if it's emphysema or bronchitis. And Noel, the one about Derm. So on bronchitis, it's just, the reason is after a while, you're going to kill their respiratory drive, and you don't want to do that. So while all the chemoreceptors for CO2 get very sensitive to CO2 when you get very hypoxic to help your respiratory drive, but it also can make it worse with further getting the hypoxia because of the chronic bronchitis. Okay. My dog is right there, and you know when your dog makes that one noise, you don't want to see anything, but he's fine. Okay. Um, okay, Noel, the biggest thing to know for those derm things is more of when I went through the process, what happened first, what happened second, what happened third. Especially for acne was a big one. We went through those processes as far as how the keratin will slough off and get plugged in the pore in the follicle. Then you get the collection of the oil there, which makes a perfect background for the bacteria, which is the cutiform acnes. Um, then they start eating all the sebum and oil that's there, dead cells. Then you get inflammatory response with the white blood cells coming in, neutrophils getting in the area. That's what causes the pus to form. And if it's an open one, it's a black head. If it's closed, it's a white head or the pustule. Talking about what happens with secondary reactions when that wall of that follicle ruptures. All those all the pro-inflammatory contents are now dispersed into the surrounding tissue, causing further inflammation to the surrounding tissues. That can happen naturally and also can happen physically when people pop their pimples. As far as some of the other diseases, let me just pull up that slides. Hang on. Okay. Really understand what layers, make sure you understand, obviously, all the definitions that we went over, as far as all of the different sizes. And again, I know this was something that came up, I overheard, but remember that 10 millimeters is 1 cm. It is even between Pulm and Derm, between the two. So make sure you understand the definitions, the descriptions of all of the dermatological disorders, the plaques, vesicles, bulla, pustules, blisters, wheals, all those fun things. So just all those different words we went over in the beginning, all the pictures, and how to describe them. What's the differences between the like petechiae, purpura, and ecchymosis. Also know like perivascular dermatitis is hives. So we went through the selected disorders. We talked about the type or the pattern that it was. So psoriasis is psoriasiform dermatitis. Know the big things. Our psoriasis has the silvery scales, sharply marginated erythematous, so a red base to it. Fixed plaques. Know the other clinical manifestations. It can happen in the fingernails. The nail beds is the one of the other clinical manifestations of psoriasis, and obviously we have the extracutaneous manifestations like psoriatic arthritis, so it gets into the joints. Interface dermatitis has the vacuoles in there, and then you start getting into the lichen planus, causing all those eruptions of all the little the Wickham striae, those eruptions of those pruritic polygonal purple papules. So all those little things to help you remember those different diseases. Understand erythema multiforme and what causes it is so when you're studying, again, is erythema multiforme important? Is it common? No, it's very uncommon. You're not going to see it. However, if you understand what the etiologies are, history of herpes, simplex virus, reaction to medications, idiopathic, we don't know. But again, if you start seeing certain things pop up, you go through their history and you hear what their background is, what's going on, so on and so forth. Know the different severe forms of erythema multiforme major. When it gets to the vesiculobullous dermatitis, I mean, it's very easy to remember vesiculobullous. You know, you have big blisters, separation of the layers of the skin. Vasculitis, all little ruptures, so they have a palpable purpura because they have little splinter hemorrhages on all the little capillaries, and blood is going into the skin, so you have it's palpable because there's blood in that layer. Understand what will cause someone to have vasculitis and so forth. Spongiotic dermatitis, just remember that's allergic contact dermatitis. This is your type 4 hypersensitivities. Then that should remind you everything that you learned in the first unit with regards to the type 4s and the rust dermatitis, the nickel allergies, and then, you know, think about all those things. Spongiosis, so you know you have a lot of edema going on, a lot of, you know, serum, plasma infiltrating, mostly serum, serous fluid infiltrating into that interstitial space, causing the swelling to occur. Spongiotic. That's why I have weeping wounds, where it's like the wetness keeps dripping out of those wounds because of the edema that's going on, constantly pushing fluid into the area and causing it to happen. The big thing with paniculitis is the erythema nodosum. So remember, with the paniculitis, it's a disorder of the fat layer itself, subcutaneous fat. And because it's so deep, it presents as those red bruises and everything that goes along with that. The nodular dermatitis, so you have nodules now. So this is your cutaneous sarcoidosis. We talked about that, how it has the lupus pernio, which is all the granulations under the nasal folds. Also, from breathing all that in all the time, you get the perihilar lymphadenopathy with those patients. And the last one we went over was the acne, the folliculitis, and the perifolliculitis. So, Noel, I hope that was a quick little summary for the derm diseases. Okay, talking about FEV1, FVC, and TLC. So, TLC is just your total lung volume. How much air can you get in and out of your lungs from the very, very peak of inspiration all the way up to the top, all the way down to the maximum expiration that you can do. Whatever this volume is, that's your TLC. Now, when it comes to FVC, that is your forced vital capacity. This is you actually being very, very, I wouldn't say violent, but you're being very deliberate as far as you breathing in as fast, as forceful as you can, and getting all that air out as fast and forceful as you can. So what happens is we get a graph on a spirometry. And I'll do one color for the normal. So when you breathe in, you get this part of the curve. So this is your, so that brings you that part of the curve. And then as you breathe out, forcefully exhale it out, you push it all out, and then it slowly comes back down to normal. The x-axis is volume, y-axis gives you more of the flow. How fast is this stuff moving? Now, the width of this entire blob, whatever you want to call it, is your FVC, your forced vital capacity. It's a number. And what we want to know is, in 1 second, how much air did you exhale of your total FVC? How much air did you get out in 1 second? And again, the magic number for that one is 80%. We want you to be able to get, if you were able to get in, your forced vital capacity was, let's say it's 4 liters. We want you to get out 80% of that. So what is that? Like 3.2 liters of that 4 liters of your forced vital capacity should be able to get out of your lungs in 1 second. And we look at how well you perform that and do all that. If you have we do a measurement, we give you a bronchodilator and your numbers improve, that could be a sign again of asthma. The converse is also true as well. If you have you do a spirometry test and you do this forced vital capacity and you have them breathe in an irritant or stimuli that will trigger their asthma, and then you do it again and the numbers reduce, that can also be a sign again that they have asthma as well. Now, with this forced vital capacity and this FEV1, this is a normal patient and what it looks like. We have great flow going up and down. Now, in a patient who has, let me just erase some of this stuff here. Lung diseases. If they have COPD, remember that COPD is a problem with flow. So it's a flow problem. So because we know it's a flow problem, we know the problem is going to be along the y-axis because this is a flow issue. So what do we see in a patient with COPD? A lot smaller circle, but the volume is okay. So it's an obstructive disorder. You're obstructing the flow of air, reducing your ventilation. So the white is the COPD. And I'll pick green now. So let's talk about restrictive diseases. If you're restrictive, you're restricting your ability, let's say if you just straitjacket yourself, if you are restricting your ability of your lungs to fill, you're going to have a volume problem. Just like with restrictive heart disease, it's a filling problem. It's a volume problem. It's not a pressure problem. It's not a flow issue. It's a volume problem. Same thing here with restrictive lung diseases. Idiopathic pulmonary fibrosis. It's a restrictive disease. Now, because they have this interstitial problem, they have an enhanced recoil. So the flow is actually going to be okay. The problem with restrictive is volume. So their flow charts will look like this. Very, very, very narrow volume, but the flow is okay. That's restrictive lung disease. That's the pattern that you'll see on a spirometry test in a patient who has restrictive lung disease. Okay. Let's see what else. I did that one. Okay, cor pulmonale and pulmonary hypertension. Let me just pull up my notes. Okay. So, cor pulmonale is an umbrella term, and it can mean, it's like we're drawing a penguin here, right? Or Wednesday, whatever show you're watching. So it's an umbrella term that encompasses a bunch of different disorders. The key thing is it's disorders that cause right ventricular failure due to a lung disorder. So the umbrella term, let's Okay, hang on one second. So these umbrella term, uh, here it is, includes massive pulmonary embolism in the acute phase, as well as your injury due to ARDS, so on the acute side, but it also includes your pulmonary hypertension is included in here, your interstitial fibrosis, which is the restrictive disease. These are examples, again, these are all examples of cor pulmonale, which is right ventricular strain, failure, stress, whatever you want to call it, due to a lung disorder. These are all lung issues, not really dealing with anything related to the left side of the heart. Because remember, the most common cause for right-sided heart failure is left-sided heart failure. But there's a small population, they have cor pulmonale, which again, right-sided failure due to a primary pulmonary issue. So I hope that answers the question regarding cor pulmonale and pulmonary hypertension. Okay, TB. We went through a little slide chart here. If you are exposed to TB, remember, like 90% of people, nothing happens to that person. They're exposed to it, body takes care of it. It never gets past the bronchial tubes, never gets deep enough into the alveoli to make its way up into the apices. It doesn't get that far because you have an intact immune system, so nothing happens with those people. Then, about 10 to like 20% of people, will become infected with the TB. Now, after that, though, where's my slide here? Of the people who are infected with it, majority of those lie dormant. Nothing ever happens. And they're also not infectious. The other set they are infectious, and they will have all the signs and symptoms of TB. And then at this point, you either treat it or they're untreated. When it comes down to all the area down there. If you are in this dormant category, this is when you get your GON complexes, because you have an intact immune system, which is all these macrophages are going to grab onto this bacilli, surround it, encapsulate all this stuff to make it into these little quarantine zones. Then over time, these little GON complexes, they're not gone yet until they become calcified. They're calcified, that's when you start seeing them on x-rays, because now they're calcified, they'll show up on the x-ray, which means you've been exposed to TB, but you were never infectious with it, but your body has taken care of it, so it's kind of like hanging out there. Sometimes those can rupture, and that's why it's called latent TB. You won't be infected with it for a long time because those GON complexes are there. And then for some reason later on in life, you may get sick. I don't know. But they open up and the bacilli that are there get back out and they become infectious. So that's where the latent TB comes in. Let's see. So obstructive diseases will have a decreased FEV1 FRC, yes. So the percent will go down, and the restrictive diseases, yeah, so in normal, 80%, less than 80% is your COPDers, potentially greater than or equal to 80% will be your restrictive lung disease patients. So the question is, with idiopathic pulmonary fibrosis, would there be a ventilation or a perfusion issue? So the issue with idiopathic pulmonary fibrosis, it's a lung problem dealing with the lung tissue. So whenever that happens, it's always going to be a ventilation problem because you're losing lung mass. So that will reduce the ventilation. Remember, your ventilation is the sum of all the air that comes in, but then also what gets to the alveoli. So as you start losing alveoli, our lung tissue, the amount of your lung that you can perfuse goes way down, so your ventilation drops as well. So the volume in the lungs, only counting the air that's in the alveoli. No, we're talking about ventilation. So we'll measure your tidal volume, and we'll multiply that by your respiration rate. So remember, ventilation equals tidal volume times respiration rate, and Q is your stroke volume times heart rate. So flow over time. And that gives you your, so liters per minute. It's just air going in and out of your lungs. In general, we see increased CO2 with our obstructive diseases because we have an issue with airflow, and see a decreased CO2 with restrictive disease. No, because the issue with CO2 is really with the emphysema patients because they can't they can't ventilate well. So that's why I have the pursed lip breathing to really help them breathe, and that's the problem. So they have lung destruction that doesn't allow for great ventilation in the lungs, so therefore diffusion is not great. Therefore, they retain CO2. The chronic bronchitis patients, remember, they're the blue bloaters. They're blue because they're hypoxic. It's not really the CO2 problem, it's a hypoxic problem. Yeah, so the hypercapnia is mainly associated with emphysema. That's why they're pink. Okay, so let's go over this one. So the question now is, so we talked about VQ. Now we're saying that in interstitial pulmonary fibrosis, it's a disease of the lung parenchyma, the lung tissue. So instead of being 4, now let's say we lost half of our lung mass, so therefore we don't get half of the lung for ventilation, or our breathing is so bad. Our ventilation went down, we have bad airways and whatnot. But we're still going to have a normal cardiac output. We're still going to be perfusing the lungs. There's still going to be diffusion of oxygen and CO2 going on. So all that happens is just the number gets smaller and smaller because you're losing airway, you're losing ventilation, you're losing lung tissue. So I hope that answered your question, Jimmy, on that one. Okay, they're caught up on questions now. Okay, while I'm waiting for more questions, I'm going to go grab some more water. I'll be right back. Nothing new for questions yet. Let's see anything else. No pulmonary edema. Make sure you know the three different causes for edema: the hydrostatic, epithelial, and endothelial damages. And what are the causes? What are the examples of them? Because there'll be some form of a question of one of those three, I'll tell you. That's a very good test question. Cardiogenic versus non-cardiogenic edema. Pulmonary effusions, differences between transudate and exudates. Different types of effusions that you can have, like what are the contents of it. And causes. Okay, hang on, I know I got a question. So the endothelial cells are within the circulatory system. So if we have, let's do this one. So if you look at, this is a blood vessel. This is the epithelial. So it's a damage from the inside damaging the inside of the blood vessels. The endothelial is the layer on the outside protecting the interstitium. Is the endothelial. So it's on the outside. Surrounding. Cardiogenic is CHF, and yes, mitral stenosis, because they're going to cause the backup for heart failure, and non-cardiogenic ARDS, pulmonary edema. Cardiogenic would have pink frothy sputum because of the increased hydrostatic pressure bursting those capillaries. Understand pulmonary embolisms, what happens there. Understand the causes of the DVTs. So a pulmonary embolism is a perfusion problem. It's not a ventilation problem. So in a pulmonary embolism, I exaggerate these VQ numbers, guys, just for math purposes. They aren't as drastic. They can go crazy, but I do it just for demonstration purposes. But in a PE, the problem is with perfusion, because now you have a clot, you're occluding the artery, no blood can get through, therefore no perfusion, no diffusion of oxygen, therefore they become hypoxic. So in these cases, the V still remains at 4, But now the Q can go down to 3, and now, we're 0.75. And we go lower and lower and lower. That's not right. Not 0.75. Hold on. It's higher than, it's like 1.333, whatever. I don't know. It goes higher. Math was weird. Okay, there you go. That's the right math. And ARDS is caused, acute respiratory distress syndrome is the need for intubation, but when you have a bad intubation, it can cause those problems. But the acute respiratory distress syndrome is not caused by intubation. It requires intubation, if you want to think of it that way, because you're trying to protect the airway. The patient cannot use their own mechanics of breathing anymore. So we have to do it for them, but sometimes just the act of intubation sometimes can cause the edema to form. No, in Virchow's triad, that one slide that has venous stasis, and it has a bunch of different examples of what would fall under that would cause venous stasis to be an issue. Bed rest, immobility, your arrhythmias, hypercoagulability. Why would someone be hypercoagulable? And then obviously vessel wall damage. Those are the 3 Virchow's triad, but what are the examples of each one? What is their risk for developing a DVT? They'll be written out fully. I won't make it like that. My point was just be careful when you're studying and you're writing your notes that you don't write PE, 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 and now you forgot your map of which one was which and confusing yourself. So it was more for you guys when you're studying, when you're writing PE on things and you're jotting things down, to not confuse yourself that way. I would not put the answer is not going to be PE on the exam. It won't be, A. That won't be an answer. That's not right. So hope that answers that one. I think we're caught up on questions. Okay. Give you guys a few more minutes. This one. You don't need to know how to describe tram tracks, just know the word. If I mention, I'll say that there's like train tracks or lines on the x-ray, I would describe tram tracks. Or if the question would be, you have a patient with chronic bronchitis, what would you expect to find on x-ray? And I would put, tram tracks or, enlarged cardiac silhouette. Those are also with chronic bronchitis. But if I put like flattened hemidiaphragms, hyperinflation, that's emphysema. So like know it in that respect. Gabby, I wouldn't go in that much detail on those, but know which ones do. I did specify and go over which ones were more so with those type of reactions. So those are the ones that I went over more. So Alexis, what I was talking about was there was a slide on the pulmonary lecture that um, talked about hydrostatic as a cause, and this was your CHF and your mitral stenosis. And then it had epithelial damage, and then it also had endothelial damage. But then I went further. There really is either it's from a cardiogenic cause or it's a non-cardiogenic cause, and the examples were just know what they were, because this is going to be a non-cardiogenic cause of pulmonary edema. ARDS falls under this category. Irritant gases, drowning, these are all non-cardiogenic. And then just the cardiogenic was due to increased hydrostatic pressure. Yep, so if I draw it out a different way, we can say cardiogenic, hydrostatic, the non-cardiogenic is the epithelial and the endothelial damage. You're welcome, Alexis. Any last minute questions? Okay, I don't hear any questions, so we'll wrap it up a little early. Good luck, everyone. Hopefully this one's a little more straightforward. Again, you're going to have some cases, some straightforward questions. Work through those cases like we talked about. Go through, if you want to go right to that last question so you know what are we talking about. And then as you read the question, you can already have in your mind, is this a process question, a pathophysiological process question? Is it a sign question? Are we looking for symptoms? What's the reason for it? And then as you read through that case, you kind of have that in your mind already to look for. So lung compliance, think lung compliance again as like heart compliance. If you lose compliance, you're not going to be able to expand the lungs to accommodate volume. Remember, in the lung, the pressures are reversed. As you breathe in, the pressures drop to allow air to flow in. They don't drop as much because of the loss of compliance, therefore less air can get in. So it's a stiff lung. They can't really expand because of the loss of compliance. So it doesn't stretch more. When you lose compliance, the stretch goes down. So in the answer to your question, vasculitis and erythema nodosum, vasculitis, remember, is a palpable purpura. You're going to feel their bumps. Erythema nodosum is all deep, not well demarcated. It looks more like bruises. So that right there, just the description will tell you what they have. I wouldn't say if they have a strep infection, what are they susceptible to getting? I'm going to list both of those. That's too confusing. But I would say they present with XYZ, and then you should know what the description of vasculitis is, what's the description of erythema nodosum that would make sense in a question. How's cardio going? So as you see, this is your third time getting cardio now. EKG is reinforcing a lot of the things you learned in cardio, how to validate what you think they may have, and so forth. Bullous pemphigoid can be. It kind of acts like one, almost. That's why the skin like separates right out. It kind of attacks that layer. I'm glad you're enjoying cardio. Okay, then, well, since this stream has nothing to do with the school, this is all fun for me. I'm going to show you guys a fun video. This is a comedy show that has a lot to do with, well, the skit is all medical, and I will leave you to watch this. Let me know if you don't hear it. But it's funnier now that you guys understand all the anatomy. So I will leave you with this. Okay. I gotta see if you can hear this first of all. Hang on. So let me know if you don't hear anything. I'm starting it now.
One time my cousin, he tore open his ball sack trying to do a skateboard trick and he had to show it to his mom.
Is it scrotal sac?
You know, that dangly piece of flesh what hangs down behind the penis.
Scrotal sac, but not sac.
So he tore his ball sack open trying to do a skateboard trick and he's got to show it to his mom because apparently one of his testicles is showing.
Is it the right one or the left one?
Why is that?
Okay, let me start over again. Hang on. Very low volume. Okay, let me find out the right setting here. Okay, it should work now. Yeah, it should work now. I got that fixed. Let's
My
see.
cousin, he tore open his ball sack trying to do a skateboard trick and he had to show it to his mom.
Was it his scrotal sac?
Well, you know, that dangly piece of flesh what hangs down behind the penis.
You all good
Scrotal
now?
sac.
The nut sack.
So he tore his ball sack open trying to do a skateboard trick and he's got to show it to his mom because apparently one of his testicles is showing.
Was it the right one or the left one?
Why is that of importance?
Well, because the left one has more sperm in it.
Spermatozoa is what it's called.
Tell you what, if I ripped open my ball sack trying to do a skateboard trick, I'd be more worried about seeing my vas deferens.
Well, you'd have to tear your ball sack pert near wide open doing a skateboard trick if you wanted to see your own vas deferens.
I'm not sure I want to see my own vas deferens.
Enjoy the anatomy.
I think if I saw my own vas deferens, I'd be quite worried.
I'd be most worried if I tore my ball sack open trying to do a skateboard trick if I could see my accessory glands.
Well, you don't want to go too kooky with accessories on your truck or your Jeep. It's okay with like a quad though, like my buddy Big T's got a snorkel kit on his and that's pretty punk rock.
What's an accessory gland?
Well, if your vas deferens is your sperm ducts, the accessory glands is what supplies lubricant to the sperm duct.
I think if I ripped open my ball sack trying to do a skateboard trick, I'd be most worried about seeing my seminal vesicles.
Or like the Florida State seminal vesicles?
Like the sac that hangs behind your vas deferens that contains fructose, which is energy for the sperm.
Yeah, it's like when you go in the city there and they got them charge stations for the people what drive the electric cars. That's pretty much your seminal vesicles.
I thought it was pretty funny when I said Florida State seminal vesicles and nobody laughed.
Okay, have a good night, everyone. I'll see you all tomorrow morning.